Hello and welcome to the Lifting the Iceberg podcast. My name is Tyler James Berger, and on this episode, I talk to Ross Divers. Ross is a researcher in the Cognitive Neuropsychology Lab at Temple University who is currently researching the use of virtual reality therapy in order to treat Alzheimer's and dementia. We explore that and more in this episode, so without any further ado, please welcome Ross Divers. So I'm sitting here with Ross Divers. Ross, thanks so much for doing this, man.
Thanks for having me.
Yeah, I'm excited to talk with you about your research. But first, before we get into anything, can you just tell the audience a little bit about yourself and what you're doing at Temple?
Sure. So, like Tyler said, my name is Ross Divers. I am currently a 4+1 Master's of Science student in the experimental psychology program here. My research broadly focuses on Alzheimer's disease, sort of the progression from healthy aging to dementia, specifically looking at how folks function in their day-to-day lives when we transition from healthy aging to dementia. That everyday functioning is so important that's what patients really care about. They're not coming to us for, I'm concerned about some proteins in my brain. They're concerned that, can my mother stay in the house by herself? Is she safe, or does she need to be moved to a nursing home? So that is really how I became interested in studying everyday functioning. What I'm doing now for my master's thesis is exploring a non-immersive virtual reality paradigm of everyday functioning to aid with cognitive rehab for older adults who are starting to experience some dementia symptoms.
Mm-hmm. Now, what exactly is dementia? Because this is a term that I've heard where it's not that you have dementia or that that's a exact prognosis, but rather it's something that is comorbid with another pathology like Alzheimer's. But so what exactly is dementia?
So your description was exactly right. A lot of times we think of dementia as sort of the disease, but really dementia is the symptom. It is quite simply just major cognitive loss and loss of functional independence. And you can have dementia due to a wide variety of neuropathology. Alzheimer's is the most common, to the point where people think Alzheimer's and dementia is synonymous when it really isn't. There's also, vascular dementia, which occurs from multiple vascular incidences such as strokes and infarcts. There you can have Parkinson's disease dementia, which a lot of people don't know about, that your Parkinson's disease progresses to the point where you also have dementia. Lewy body dementia, you can even technically have a dementia from repeated head injuries.
Yeah. So what are some of the behavioral expressions of dementia? Like, when exactly can you see it in someone?
So some of the earliest signs we typically look for in dementia is there's often sleep disturbances. There are often mood changes. People become very irritable. They might start obsessing over some pretty interesting tasks, like obsessing over cleaning, obsessing over trying to keep their valuables safe. Those are some pretty hallmark symptoms. And then, since I'm an everyday functioning person, something we notice a lot in specific Alzheimer's variant patients is the first sort of everyday task to go is balancing the checkbook and maintaining finances. We really see that that's a vulnerable...
Things that take conscientiousness and ordered thinking.
Exactly.
Yeah. My grandmother later in her life had dementia, assumingly Alzheimer's, as a result of Alzheimer's, and she began to hide money all over her apartment. And when she passed away, my mom was going through her things, and she found hundreds of dollars, of dollar bills, tucked in between couch cushions, inside of a book, inside of a sock in the bottom of her sock drawer. And we think later in her life, she just developed this strange impulse of hiding money all over the place. So it's strange how some of these things can manifest as the result of these neurodegenerative diseases.
Yeah, it is something that a lot of people don't think about when we talk about dementia is, the common symptom is memory loss. But there's a host of what we call neuropsychiatric symptoms, which are more sort of mood and behavioral that accompany the disease. And a common one with Alzheimer's specifically is just sort of feeling unsafe, feeling like you have to hold on to your belongings, in the case of your grandmother, hiding money. But some interesting things we see in Parkinson's disease dementia is they become riskier with the sort of more risk-taking, less inhibited. That can be a major problem with Parkinson's patients who are still in charge of their own finances.
Yeah.
They can go on sort of excessive spending sprees and do impulsive sexual behaviors, which can lead to obviously a host of other problems.
Yeah. Evidently, there's a big problem with people in nursing homes having sex.
Yeah.
Do you know anything about that? And how related to is dementia to that?
I would say, it certainly can contribute to it.
They're just like getting dementia, losing all their inhibitions. It's like being drunk pretty much, like, because that's the kind of same effect that alcohol has, like kind of decreasing inhibition. So pretty much get a bunch of drunk partying senior citizens in these nursing homes, right?
Yeah, I mean, it's important to think that, this not all patients with dementia experience this, but rising numbers specifically with the Parkinson's variant do have this sort of like loss of control,
which could heighten sexual promiscuity. Yeah. So now these are all kind of qualitative analyses of how you can tell when someone has dementia, but what kind of tests do you run to kind of give someone a diagnosis? Like, is there something that you do when you bring someone into the lab to kind of like test their thinking?
Yeah, so there are a multitude of ways, and it's typically done between a neuropsychologist, like what I'm hoping to be one day, and along with a neurologist. So the neurologist typically handles more of the imaging, the blood tests, which are very helpful in sort of narrowing down other sort of conditions that could be going on. But the role of the neuropsychologist is, once it's established that there is, sort of a medical problem, bringing in the person to then perform very standardized, rigorous cognitive testing to test different thinking abilities, long-term memory, short-term memory, language, attention. And what you get with that is really a profile of how their cognition, how this person is functioning, along with their, medical, physical health. And what that is useful in determining is all of those different cognitive abilities have different neuroanatomical correlates. So you can really it aids with figuring out which parts of the brain are being damaged. So with what we typically see in Alzheimer's patients is severe problems with not long-term memory per se, but making new memories. And that is, sort of the hallmark symptom of Alzheimer's. And that's due to damage to the hippocampus, thought to be due to amyloid and tau buildup in the brain.
Now, is your research focused on prevention at all? Because it seems like when someone starts to develop Alzheimer's, there's the only thing you can really do is try to slow down the progression, or to help them maintain some level of normality in their life. Is it really something that you can reverse?
That's
or prevent, like.
That's the $1 million question.
Yeah.
Is it? So, in terms of that, really growing area of research is focusing on the precursor to dementia, what we call in the field mild cognitive impairment, or MCI. And MCI is a very curious sort of condition because if one develops MCI, it's, you're much more likely to go on to develop dementia. But we do see cases where people remain at MCI, or some even do reverse. So there's a lot more research that needs to be done on sort of profiles of MCI. What I hope to add to the field one day specifically is medications have largely failed for dementia treatments. The current one that is prescribed is Aricept or donepezil, which is effective for some people but is not effective for all individuals. What I am hoping to add to the literature is really sort of understanding modifiable risk factors for dementia. So in the literature now, we know there's a host of things like weight, cardiac health, depression, and of course genetic history. Those are some things you can't do about it, but weight and vascular health is huge for dementia, and so is things as simple as education and social economic status. So something I would love to add to the field one day is sort of understanding these modifiable risk factors and then actually implementing them.
Yeah, I mean, I've heard things, the obvious things in diet, like incorporating different types of healthy fats. Like I've heard walnuts or omega-3s, fish oil, krill oil, EPA, DHA, things like that. I've also heard that reading can be one of the most powerful modifiable risk factors, just because that's a way of exercising your mind, your brain, your ability to think episodically. Do you know anything about the effect of reading on Alzheimer's?
Yeah, so reading is something we definitely recommend, and what's becoming anything sort of that keeps you stimulated is good. So, a lot of those, brain training games and apps get a bad reputation, but while they don't do, I think, what they are marketed to do, they are better than, sitting down and watching TV. And something that is really becoming sort of prominent in the literature is social engagement. There's something about going from, a 9-to-5 job to retiring and isolating yourself that seems to be really terrible for the brain. So that social interaction piece, I would say, is something I would encourage to older adults. In terms of minerals and diet, like you were saying, what's commonly what we recommend to patients now is the Mediterranean diet. In terms of minerals, there's a really interesting neurology research group in China that is a big proponent of magnesium, just really keeping magnesium in the diet. That seems to, they have some findings that helps to stave off cognitive loss. No large-scale trials yet, but that's something I've seen pop up in the literature a few times. Now,
something that I'm very interested in what you're doing, this is kind of what first turned me onto your work, is you are using virtual reality programs, non-immersive virtual reality, to create tasks that help patients with Alzheimer's practice day-to-day activities, or rather, can you explain more about what you're doing specifically with the use of virtual reality to help patients with Alzheimer's?
Sure. So I love talking about this. It's my sort of the first project I've done from the ground up. There was an excellent paper, the best paper I've ever read, that came out in the Journal of Neuropsychological Rehabilitation in 2015, by a French neuropsychology group that did a single case study with a woman with severe impairment due to probable Alzheimer's disease, where they took her and they had her practice just everyday tasks, 2 tasks on a virtual system and 2 tasks with real objects. And what they found after all of this sort of training and rehabilitation was that both tasks improved, all of the tasks improved. This was really the first paper of its time that showed that there is benefit from this virtual training, and it's just as comparable as training someone with real objects, because we have the capabilities now to, employ an occupational therapist to come in and practice everyday tasks.
And these
with somebody.
tasks are like, okay, here is a fork, a knife, and a spoon. Put the fork, knife, and the spoon into like the correct placement, or something.
Yeah,
Like, can you explain what one of these tasks looks like, both in like objective reality and in the virtual reality system?
Sure. So they are relatively simple ADLs. They are, prepare a lunch for somebody, pack a school bag for somebody. There was a gift wrapping task, but we no longer use it because some people just don't know how to wrap a present correctly and will perform like someone with dementia.
Yeah.
So with that particular French woman, they designed typical French daily tasks. So preparing soup, heating up soup in the microwave, preparing a cake for someone was a more advanced task. But that's what my work has also focused on, very simple tasks. So right now I'm working with a simple task of packing a lunchbox with a sandwich, a drink, and a snack, and preparing a breakfast for someone who wants toast and coffee.
Mm-hmm.
So when I read this paper and saw, I got really excited by these results that, this woman showed improvement comparable to, on a virtual system, comparable to what you could gain with real objects. With the goal, of course, the benefit of the virtual training is that it could be done by themselves. And so the finding, though, was that after 6 months post-training, she lost the benefits, which is to be expected.
Is it something that, like, ideally, how would you prescribe the integration of these tasks into one of your patients' life? Like, is this something that, like, you would give them a set of tasks to do on their iPad, like, every morning or every night, so they can kind of retain that the motor function that comes with those tasks throughout their day? Or how exactly do you integrate these tasks into the patient's life?
So that is the goal now with when I decided to pursue this type of research, I wanted to recruit more people, obviously, because there's only one case study that had been done on it. But I also recruited people with more mild dementia to see if they get a lasting benefit from this. And a major goal with this research is to see, how often would someone need to practice with this system? Do the benefits go away after a single day? Is it a sort of an exercise that you need to work on every day, but it can keep you out of a nursing home, keep you just functional enough to stay out of a nursing home? And what we're still collecting data, but what we are finding so far is that there are real world benefits to this virtual training. That training, not only does it improve when you train one task on virtual reality, it improves the same task with real objects, but in fact, it improves your performance of real tasks of similar difficulty. So there is some carryover to.
Oh, cool. So the task, the skills and practice effect from the tasks are transferable to related tasks that people experience in their life.
So how we've been organizing the study is participants will only receive training for one task. So they'll only be trained on the virtual breakfast or the virtual lunch. But then when we assess them with real objects, we make them do both the task they were trained on and the task that they were not trained on. And what we're seeing is there is improvement for both the task that is trained and not trained. But what we are also noticing is that it's seeming so far that training gains, so improvements, are much larger within one training session than across. So what that is suggesting to us is that this indeed might be something you have to do every day, or else you'll lose the benefits gradually.
Yeah. Now, why exactly are you using two-dimensional virtual reality as opposed to immersive virtual reality? Is it just an artifact of the expense of the immersive systems, or how hard it is to create virtual immersive software?
So it's a bit of both.
Yeah.
It's, as a young graduate student, I have to use what is available to me, but also there are benefits to using non-immersive virtual reality. A lot of older adults, especially in our area of Philadelphia, are skeptical of research in general, let alone, something with a technology they're not familiar with. Also, a lot of older adults in particular get motion sickness from immersive virtual reality. In a way, we sort of counteract using non-immersive virtual reality, but wanting to keep it, as naturalistic and real as possible. It is on a touch screen that they have to touch the objects, but also, for spreading peanut butter on bread, for example, they have to get the peanut butter on the knife and then do sort of a spreading motion with the bread. We think that sort of, counteracts that. It is not immersive, but they do still have to pretty much perform the action.
Yeah. Now, have you theorized much about the potential for immersive virtual reality and these different kinds of tasks? Like, what are the potential plus sides of the immersive VR with the creation of these tasks, and where do you see this going in the future?
So, interesting question, because where I will be after I graduate with my master's at Temple, I am moving on to my PhD in Louisiana State, where I will be expanding to immersive virtual reality tasks. And I do want to sort of explore both sides, see the benefits of both. The main benefit I see to my work with immersive virtual reality is, we're working with everyday functioning. We want it to be as real world as possible. So you would want it to be essentially as real world as possible. So it makes sense to implore and to use immersive virtual reality.
Yeah, and something that I know we talked about a few years back, the first time I interviewed you, I asked you, what do you think the potential is of people with Alzheimer's becoming more apt at all of these tasks in the virtual reality than they are in objective real reality? So much so that they would rather stay in the immersive VR system than leave and try to integrate that into their life. Like, wouldn't they have some kind of desire to just stay in the virtual reality system where they can maintain some kind of sense of independent functioning?
That's definitely I remember you posing this question to me now, and it's such an interesting thought, because it's something I haven't thought of until you raised it to me. And that is something we might even see when we put folks in immersive versus non-immersive.
They're not going to want to come out.
I mean, it is a possibility. From just working with older adults with the non-immersive system, they enjoy it. They view it as sort of a game. I wouldn't say they enjoy it so much that they
become addicted to it or anything.
It's almost like working with older adults in research is interesting in that oftentimes they're happy to do whatever you want them to, because it's social interaction for them, it's someone to talk to. So I feel like that sort of is a one-up for why they are enjoying the system. But I am curious to see, once I do a shift to immersive virtual reality, are we going to see, I prefer the virtual system. It's easier than doing real world tasks. But something that is interesting with the virtual paradigm I'm working now is it's very customizable. That's sort of the benefit of it, to where you can, the goal would one day be, if this proves to be a reliable treatment, you can customize it with someone's exact, objects and what the brands of the objects they use and have used for their whole life look like. And you can program it to do the exact tasks. Like, let's say it's very important for an older adult to be able to make coffee for themselves while remembering to turn off the stove and balance a checkbook. You could set up this system so those are the two tasks that they need to train on every day. And that's, when we get retired and older adults, there aren't too many things that we really need to do, but there are certain tasks that make the difference between staying out of a nursing home and not. And so that would be sort of the goal one day, to implement these essentially virtual exercises for people.
Yeah. Now, do you gamify these exercises, or is it really just the virtual equivalent of making coffee or putting peanut butter on a sandwich? Like, is there a point system? Do they get gold coins like when they spread that peanut butter really well?
So that is, that's interesting. And it's, again, something I hadn't considered until like when you're actually on the ground doing this type of work. People want feedback. People want like rewards. So they want
that little dopamine hit.
So we've added even like when you're first introducing them to the system, we've added like little sounds and music when they do it correctly. And for another project I'm working on with the lab, it's another smart technology. It's not virtual reality, but we're calling it the smart prompt. Essentially, it's a very sophisticated alarm clock where you can program it to set alarms to remind someone to do a very specific task. And then the follow through is it requires the person to take a picture that they've actually done the task.
Oh, interesting.
And we've programmed the system to where if they like complete all 4 tasks that the person programmed in, it then shows them like a little video of a puppy. And
this is like an app on their phone?
Yeah, it's an app on the phone.
That's awesome. That's a great idea.
It's been really fun. A lot of folks are really enjoying the smart prompt.
A video of a puppy? That's the reward.
You could even program it to, theoretically, we've talked about, programming it to so they get like a message from like their grandchild or something. A puppy.
Or some money.
Well, yeah. Or, I mean,
sweat coin, kind of.
Yeah. I mean, theoretically, you could. Yeah.
Yeah. Where would that money come from, though? Where's the funding coming from?
Well, that's why I said theoretically.
Maybe it would be like, in a way, like it could be their own money. Like if they're paying for this service, then they get some of that money back through the incentive reward system.
Right. I mean, the goal of this would be a device that's essentially set up by someone's caregiver. So, I mean, it could really be up to the caregiver, whatever they want the sort of reward to be. If it's someone who, is to the point where they are not financially independent but wants to be, maybe it could be like almost like an allowance. Like you did, you remember you completed all of the tasks that you needed to today, so here's your reward for it.
Yeah, I mean, the whole gamification and creation of rewards, I could see, like, I think it's important that you've put this system on an app on a phone where people can kind of have that in their real life. But I could see a problem if an immersive virtual reality system was rewarding and those same tasks in their normal life were not. It's like, imagine if you could like make a peanut butter and jelly sandwich in this immersive virtual reality, and then like when you complete it, all these like psychedelic colors like explode, and it's like this ecstatic feeling. Woohoo, I did it! And then you take it off and you make a normal peanut butter and jelly sandwich, and there's no confetti. There's no points.
I would be more concerned about that if we were working with strictly healthy older adults, because I feel like with them there's less rewards in their day-to-day life. Like I said, that they're really just happy to talk to us. And they go along with what we do in research just because it's interaction for them. But what I found with working with folks with MCI and early stages of dementia is they are looking for anything to help them sort of improve in the real day-to-day life. So it is an interesting duality, and I am curious to see what happens when I do shift over to immersive virtual reality.
Yeah. Now, do you believe that there are any like tasks or games that have potential for reversing Alzheimer's? Or is that a possibility, or is it really just kind of staving off the digression?
I would say it's mostly with staving off the sort of
what term would you
sort
use?
of the degeneration.
Degeneration.
Yeah. We are currently now giving people post-intervention cognitive tests to see if there is any sort of just general cognitive improvement after the intervention, but so far we haven't really.
Like, I wonder what would happen if someone learned how to play chess as they start to develop like MCI.
I mean, it's definitely possible because learning sort of those more procedural things is a different neuroanatomy than like what is affected typically in Alzheimer's. So that definitely is possible. If you look at the criteria for dementia, it is major cognitive loss and functional loss. So in a way, we are staving off that functional loss and keeping it to sort of cognitive loss. The goal really is keeping folks, even if they do still have cognitive impairment, keeping them at least functional. And, it's harder to, of course, we would want to improve cognition. And there are some excellent, there are some other labs in America. An excellent researcher at University of Houston, Dr. Stephen Woods, is working on a virtual intervention for prospective memory. So remembering to remember. Which is also huge for remembering to do everyday tasks. But he's really, on the forefront in America with sort of more of those direct cognitive interventions. So there is hope on the horizon.
Yeah, and I think that what you're doing is so cool, and I love how you're integrating technology into these different kinds of medicinal platforms and these medicinal uses, really. What excites you most about where this technology is going to go in the future?
There was a particular participant that I had that before intervention, she performed. So before the intervention, we have them do both real tasks. And in my 5 years of doing this, she performed them worse than I've ever seen. But after the intervention, she performed them a lot better, and that really, struck home that this really does have the potential to
it worked.
It worked for her. So what I am really hoping is that if it holds up with more data recruitment, that this is effective in at least, maintaining everyday function, stopping functional loss, really doing larger scale trials, and eventually implementing it in the home as sort of, older adults have a medication list. Add this on that. You have your medications and you need to do your half-hour exercise on the computer.
Yeah.
That's really what gets me excited.
Yeah, awesome. And if people wanted to learn more about this or learn more about you or this intersection between virtual reality and the treatment of Alzheimer's and dementia, where can they go to find out more? So
my amazing mentor, Dr. Tanya Giovanetti, is a professor at Temple University. She's been an amazing mentor to me, but also on the forefront of this research. You can find her on any sort of Temple website. Also, if you just Google Temple Cognitive Neuropsychology Lab, our lab page pops up. You can also follow her on ResearchGate, and you can follow me on ResearchGate for I try to update it regularly on upcoming projects I'm doing, anything that I publish. I'm on LinkedIn, Ross Divers, if you ever want to follow me. Like I said, I am moving to Louisiana to continue my education, but I'm hoping to sort of stay in this field. It's really where I can't imagine leaving it.
For sure, and let's keep in touch. I'd love to interview you again, like over the next few years, just to see how your research is developing and what you're learning.
Absolutely.
Cool. And with that, the iceberg has been lifted. Ross, thanks again so much.
Thanks, Tyler.
All right, peace, everyone. Thanks again for listening to the Lifting the Iceberg podcast. You can find out more about Ross and his research by looking him up on ResearchGate or by following him on Instagram at Ross_M_D. You can stay up to date on any new podcasts at liftingtheiceberg.com or by following Lifting the Iceberg on Facebook and Instagram. This podcast is available on Spotify, iTunes, and YouTube. Thank you to Alexis Spatty for designing the graphics for this podcast. You can find her at alexisspatty.com. And thank you to Caruso for the soundtrack Stay With Me. You can find Caruso on Spotify, YouTube, and SoundCloud.